Healthcare to prevent and reverse diseases of aging is the future of medicine. For me, it's my past and future because I've been doing this for over 2 decades. But if we hope to win the battle against chronic disease like diabetes, heart disease, obesity, dementia, cancer, we have to really shift from reactive medicine that treats disease once it presents and emerges to really being proactive beyond prevention so that we can keep our health despite the aging process. Hello, and thank you all for tuning in to the Healthy Longevity Podcast. I'm Dr. Florence Comite, founder of the Comite Center for Precision Medicine and Healthy Longevity in New York City, Palo Alto, and Miami Beach. As an endocrinologist and clinical researcher, I've been practicing a specialty of proactive healthcare called precision medicine for more than 20 years. And when I began, I thought every physician worked this way, critically analyzing each individual patient for signs of early potential disease and stopping it and reversing it before it would actually cause problems. But I was a little naive. Even today, there are only about 2 preventative medicine specialists to every 100,000 people, according to analysis by the AMA. That's really starting to change as more physicians question the logic of conventional medicine's reactive approach and what they were taught in medical school, which is standard of care. Today's guest is one of those physicians. Her name is Dr. Maryam Baqir, and she's delightful and lovely and sort of made this change quite recently. So we'll get to hear what happens in medicine practice conventionally and where we're headed for the future. She practices internal medicine for Northwell Health in Brooklyn. Welcome, and thank you for joining the podcast.
Thank you for having me here. I'm honored to be in your space.
Delighted you're here. As I told you, I thought it was going to be a video. Brooklyn isn't too far away from New York City, right? And as I told you earlier, I was born in Brooklyn.
Nice. Yeah, no, it's a lovely place.
I think we could start by telling our listeners a bit about your background as a physician and what inspired you to actually pursue medicine.
Sure. In some ways, it came in easy for me. Both my parents are physicians, so it was a lot of initial exposure. My dad is an emergency medicine physician in Pakistan. My mom is in family medicine. So I was obviously exposed to medicine from a very young age. But even in terms of aligning my own interests, I did have the love for science. I remember I didn't like physics as much, but biology, chemistry were subjects that I really liked. So that sort of tuned in. And then I think at that time, even though I didn't really ask big questions about life, existence, or things like that, I still had this inner knowing that service is part of purpose in life, right? And then you can serve people in so many different ways. But the fact that I was exposed to what medicine is about, the fact that I loved biology, chemistry, the fact that I wanted to serve and help people and see if, it's corny, but we all feel that way, right? That you want to make a difference in life, which can be done in so many ways. But for me, I felt like becoming a doctor was just the choice. Like there was not a lot of argument or comparison there for me.
It sounds like you're a natural healer and most of your family are physicians.
Yeah. It came in naturally to me and I still stand by it. Like, so many years later, I still feel that I am in it for life. So it's not something that thankfully that I feel like I'm want to switch to some other field now. I don't have that at all.
You love medicine.
So I love medicine. I love speaking to people. I love getting to know their stories. And I love making that a part of their healing journey. And through them, I heal too. Like we heal each other. So yeah, I think that's where the initial start happened.
I can completely understand that as an intern. I remember when I was first on the wards on the floor at Yale, I had patients tell me things that their significant others didn't know. And the trust they put in you and the way you can help people is just kind of, I don't think there's anything that compares to.
It truly is such a precious space that I am in awe of and very thankful for everybody who puts their trust in me. They truly share the deepest, darkest secrets with you that you're right, their own loved ones may not know. And I don't take that lightly. And through that, it's just beautiful.
Yeah, I have a lot of, I'm grateful for the changes that people can see and make. So yeah, great. You did go to medical school in Pakistan.
Correct. I grew up there as well. Yes, I grew up there. I went to medical school. And then after medical school, I was briefly in Sweden. I got married and that's where my husband was at that time. My husband is also from Pakistan, but he was working in Sweden at the time. So briefly after medical school, I moved to Sweden and then we moved here for my residency. And then I've been in New York since then.
So in Sweden, you didn't have any medical experiences?
I did electives there, but everything is in Swedish there. They don't practice in English. Everything. It was shocking to me in a very good way that it was the first time, because back in Pakistan, part of it was Urdu, but most of it was English. But in Sweden, everything was in Swedish.
This is even worse in America in some ways. We're so isolated. I was always jealous when I went to other countries like Switzerland, where the kids grow up trilingual. And I know my parents were European, and so they spoke many languages. And I felt that it was very hard to even.
I was in awe of how they practiced there, like every single thing, like not a word of English in their hospitals. I worked in their hospitals.
Wow.
I did electives
there. How did you
there.
survive?
They took care of that.
Oh, that was
They
good.
were very they really honored that I don't understand Swedish. They took care of that.
Hopefully with all these AI models, we'll be able to translate instantaneously.
That is the hope.
Yeah.
That is the hope. I agree.
So you were a hospitalist.
Yes.
It sounds like you had very deep training in medicine and also advanced critical care probably before you transitioned to primary care.
Yeah.
And you bring a unique perspective as to why our healthcare system needs to shift from reactive to proactive. And I'd love to understand what led you to recognize that shift, since you're young and you just started your work in medicine the last few years.
It was an inner knowing, but it took me some time to figure out that I now have the courage and the confidence to make that step in the right direction. But I do think that even right from the start, there was always an inner knowing. And the inner knowing was really that I worked in the heart of Brooklyn at Maimonides Medical Center. It's the largest hospital in Brooklyn, one of the busiest in New York City, one can argue. I saw such sick people, and it was just shocking to me. It was shocking how sick people were. And I was getting a lot of exposure to inpatient medicine. I was getting good at taking care of sick people. I could see that my confidence in hospital medicine was increasing. I could see that I was making a difference. I could see that we were saving lives and we were doing incredible things. There was always a part of me that always questioned that, my goodness, this DKA could have been prevented. And I'm not even talking about anything like out of ordinary right now, even like basic, simple things like the kind of things I saw both in my residency and then as I spent 4 years as a hospitalist, things that I saw, the agony, the pain, the suffering, unending nature of it. It was like, even right now, I think if I talk about it, it would make me cry and all to only realize that nobody's saying everything can be prevented. And of course, there's a time and place to be in a hospital. And I'm in awe of the work we do in these hospitals, but so much can be prevented. And we don't have to be this sick. We don't have to wait till we get this sick. And I also sort of, in terms of like the conventional background, I always felt that I was probably the only one thinking like that. I could be wrong. Maybe it was something in my mind, but I felt like most people didn't question that. Like a lot of people did want to be in patient medicine and they would talk about it. But when I would question things like that, I felt alone questioning that. And then I was like, okay, I guess maybe it's probably very difficult to prevent this. So we are doing the best that we can do. And I continued to nurture my skills as a hospitalist, but then slowly and gradually, and in my own personal life at the same time, right? I was going through burnout. I was the frontline worker in the COVID pandemic. So residency in New York is already so hard on you. And then boom, in your last year, the pandemic hits. I was already going through my own burnout. I was losing weight. I was underslept, the way residency is, right? And then so much trauma at the hospital. So I was also in the process of figuring out how to take care of my own self with basic knowledge of nutrition and exercise, nothing deep, but I still had that inner knowing that these are things that I do kind of want to reflect on and take care of my own self. But then I'm like, why am I not doing this with my patients, right? And for how long is this going to go on? Because it's always that voice that hits you when you're going to bed at night, right? That, do I feel like I would love to do this all my life? And I felt that resistance. So I think it's very important to have that connection with your own self. And sometimes when they say, right, listen to yourself as well. The world may be saying whatever. And I had no training in prevention or proactivity in medical school, almost nothing in residency.
Is there any training now? There was none at Yale when I was a student.
There was I don't think so. There was primary care, but even primary care was a lot of, sure, in primary care, we do preventive care, but it was still not the kind of care I
care we do is maybe some diagnostic tests if they believe in it, whether it's a mammogram or issues with a prostate exam.
Structured stuff.
And really teaching people how to investigate, and they don't even give the students or the trainees the tools to understand nutrition, exercise, sleep. And that's where the world has changed. So you can imagine, because I went to school more than 20, 30 years ago, what I faced. There was no one. And in fact, people would laugh about it when I would say, listen, there's a better way to take care of people. We need to know more. Excellent. Do you have any real examples of patients you saw as a hospitalist to illustrate that impact, or even in your own family? When you compare notes, is it the same situation in Pakistan and Sweden, where I know you started your career? Have you heard stories, and what does your family feel about since their doctor?
Yeah, my dad is both my mom and dad, so my dad and mom, they have their own kitchen garden over there, right? So they grow a lot of vegetables on their own. So this also sort of instilled, it's not like we are a plant-based family only, like we're not vegan, but we are an omnivorous family. But there was always a very big emphasis on making sure that you're eating not just your vegetables, but a variety of vegetables. Plant diversity was ingrained in me right from a very young age. And my dad grew broccoli in his kitchen garden when broccoli was not available in the mainstream market in Karachi. Like you wouldn't find broccoli anywhere. You wouldn't find parsley anywhere. He would grow, because he would come here, get the seeds. He would come to the US and get the seeds here, and then he would go back and grow there.
Your father sounds like my mother.
Yeah, and my mom and dad take care of the garden together.
Yeah. I guess in my case, it was just my mother. My father did other things. He did the sports and the exercise.
Yeah, so because of this, my dad, being an emergency medicine physician, he sees emergency cases over there, right? So of course there is it's so common for people over there. Like the thing that really bothers me, it's so common for people there to die in their 50s, actually. 50s and 60s. Like the average age in my country is probably in its 60s.
Yeah. People say, well, they died of old age, and I'll say, how old? And they'll say, well, 60, 65. Exactly. And I'm like
what are you talking about? Right. Oh yeah, it's aging. I'm like, no.
Even when they're 90 or 100, it's not old age.
Yeah, it's the shift in how you think about life and living. It's so common for people there to die in the middle of the night. What is a sudden cardiac arrest representing? Like, what's going on? Like, how do you, of course, there's no way for me to tell.
Well, I see a lot of folks from Asia and from Pakistan and India. And in general, even when they're sick, they actually look and seem healthier. And I always wondered if turmeric and curcumin and all of those saffron are playing a role. I think it is. I think it reduces inflammation. But it sounds like it's not a great system over there either. It's worse than the States, maybe. We get all chronic diseases and we stay alive a long time, but very sick.
And if there are good genes, people will live longer there, but the average lifespan is in its 60s. So that's just the truth right now. And then in terms of what I saw here,
is India?
I'm not sure, but our demographics are similar. So I would probably think that
it's maybe, similar?
Yeah, maybe.
The average group.
My guess would be maybe India would be a little bit better, I would argue, maybe, but it's also a much bigger country. So I'm actually not sure about the statistics, but in terms of if there are good genes, I have my grandparents lived up to their 80s. So if there's good genetics, but even in their 80s, it's not like they're living their best lives in their 80, right? It's they at 60, they start preparing to die, right? Like that's how the mindset changes.
I think here at
people
60,
over
they
there
just get sick and they cope with it. You see them. And even people who have the wherewithal to get the help, I'm always shocked when I get their labs and I hear their story because no one's doing anything proactive. I had a patient call me from Atlanta, a really smart guy who's a CEO and chair of a company. And he was telling me how he has a concierge doctor. And then he went on to tell me all the things that were diagnosed. And he said, but nobody's doing anything about it. They're keeping an eye on it. Yeah. So I'm always shocked about that. Yeah, I feel like I'm living in an isolated world. So it's great to hear you.
Yeah.
In your new practice, what's your typical patient like? You're seeing patients through Northwell. You have a primary care setting now, which is different than hospitalists. Hospitalists can absorb it, but I guess it's gotten more complex at the hospital level, more critical care. Right. People are living longer and they're probably sicker when they get admitted.
They're sicker. And actually, just going back to what I saw in my practice as a hospitalist, not only are they getting sicker, I also saw a lot of people who are tracheostomy, ventilator, people who are living lives in nursing homes.
On ventilators.
That's it, right?
There's no one there to make a decision.
And that was the kind of, it's both. It used to be both. It was maybe when family members didn't want to let them go. And at the same time, there were some cases where there was just nobody to speak for them and it was a whole thing. But then, and guess why they were on the ventilator to begin with? They had a stroke. And guess what? 80% strokes are preventable. So like those kind of things, right? Like they would come back with a ventilator-associated pneumonia, and now they have a PEC tube, and there's some complication of the PEC tube. Now they have a sacral decubitus ulcer. So there's a complication of
they
that.
might chronically start going downhill, but
just going down, and we're trying to keep figuring out how to just keep them alive, stabilize, and send them back to the nursing home. And of course, sure, there's value in that. But my question always was like, what am I achieving here, right? This person is not coming back. And those are... and
cognition or memory.
It was a mix, but there were many where there was none. Maybe they would blink the eye. Maybe they would lift a finger.
It's where the cost in our healthcare system
that's
is
what
astronomical.
and that's what my frustration was. I was like, I see we're trying to help this person, but to what end and for what, I don't understand. What are we trying to achieve here? And then if I go back into how this happened, it was a fateful stroke. And then when you talk about, okay, what do we do for strokes? Once you get the stroke, there's not a lot you can do other than maybe physical therapy. I mean, there is some acute management of stroke now, which of course is very helpful.
But only if you make it on time.
But that's another thing. If you make it on time, exactly.
Now, what's a patient like? Because I imagine it's still like, I remember transitioning to New York because I didn't know anyone in New York, and I had a practice of primary care with excellent doctors. And I was ending up staying until midnight because I saw so much that could be treated, reversed, prevented in a pretty, like smart population of people. These were people that could afford to do what they wanted. They wanted help. It was insurance-based too, but it was fee for service. And this was one of those doctors I work with. He was fabulous. And he really gave excellent care. And I kind of went back into primary care roots to understand it. But there was so much to do that I felt like I had to organize an approach. And that's why I ended up doing what I did.
And I think that's what I'm in the process of figuring out as well. I became a primary care physician just a year ago after only doing internal medicine.
So how do you convince patients that prevention is worth it and it matters, or proactive prevention?
Yeah. So one of my biggest things that I really focus on is family history. And I've heard you saying also that family history is a poor man's genomic study, right?
That was the beginning because I wanted the genome to be here. And then as years went on, I realized that it was richer than genomics, at least in today's world, still to some degree, because it's emergence of diseases. Because a lot of us are programmed to get diseases we never get, or we live a life a certain way, so the epigenetic factors protect us. And so now, to me, family history actually trumps genetics for the time being. That's
I'm glad to hear that. I'm glad to hear that. I'm sure it may change exactly as we advance in the field. But for now, that's my tool. So one of the ways in which I do two ways. One is I really dig into family history. And when it comes to family history, I dig deep, including if I feel like I was not able to dig deep into family history in this one visit, I will ask them to follow up just to tell me their family history. And when it comes to family history, I'm talking about age of diagnosis. At what age did your father get a stent? At what age was this breast cancer diagnosed? When did this person die? Tell me about your paternal, maternal aunts and uncles as well. Like what's happening in the whole family.
A little fly on the wall when I had a leads call earlier today, because that's exactly the way to go about it. Congratulations.
And then that's where the light bulbs open, because they're like, oh, and then they're messaging their moms about answers, right? Oh, I just found out my paternal aunt was actually diagnosed with breast cancer at 40. And you're 35. I'm like, there you go. That's why I'm asking this question. Because if you're 35, it lights a
fire under them in a way that they realize that they may be at risk too, because it runs in their family.
Absolutely. I said, and oftentimes I feel that if you don't ask them, it's often not on their radar. Many of them maybe are not even living with their parents. So, you tend to forget, I'm not sure, maybe this, that. But when you dig and then they go back and they go talk to them and they bring back the answers, then it lights up more bulbs. So then what I tell them is that, hey, this stent that your dad got at like 65, the process of that, like I explain it to them in as simple a manner as it can be for them to understand. The process of this catastrophe started at your age or maybe even younger. So younger, right? Not even 30s. We're talking about primordial prevention now of cardiovascular disease.
You already answered the next couple questions, which I like people to think about. What is the promise? Because in order to have people take it seriously and make lifestyle changes, they have to, or make any change, they have to see themselves. And there's also the other end of the spectrum where sometimes people feel it's inevitable and you have to tell them, no, it's not. Diabetes is inevitable. attack or dementia.
That too. I tell them the same thing, that it may be there. Maybe even with the best of efforts, you may still get it. But can we at least try and see if we can push the age?
Yes,
I just don't
make
know,
it 100
right?
instead of.
Can we push the age at which you get diabetes? Or who knows, if we do it properly, we'll be able to escape the genetic predisposition altogether. The trigger of the genetics lies in what we do on a regular basis. So those are, and then also like I'll get a lot of women in their 20s, 30s, for example, even 40s, right? So I remind them, just like how I remind myself, that we feel okay right now. But this is also our time to, like, I describe it as our 401k for health. This is our time to invest in our health, to bear the fruit, not just today, but also for decades to come.
I feel like seeing an image of, I remember when I first started this work in women's health in 1992 at Yale, I would tell people that you should think of your health portfolio in addition to you work on your financial portfolio, but what's all the money going to do if you're sick, So that's a similar approach.
Some perspective shift in terms of looking at your health, giving importance, including some financial investment. For example, I give my own example. I decided to invest in a fitness trainer. I said I would buy less bags, less clothes, but I'm going to pay for a fitness trainer because when she comes in, she trains me. It's
you motivate.
It's a completely different level. Yeah, like I shared my own example with them because I don't say that I'm imposing this, but for example, if we can, like I give them my example that I decided to budget a bit differently. And I told myself I am willing to buy less bags and less clothes, but I would pay for a fitness trainer every month because for me, my health is a priority. And I see the difference that the trainer brings to my training routine. When she comes and she trains me, it's a completely different ballgame altogether, both in terms of the efficiency and the safety that is there when she teaches me. So I give them different kinds of examples. I tell them you can do this even at home. It can be zero cost as well. But depending on wherever you are, I would like to meet you where you are. If you can't afford a fitness trainer, no problem. If you can't afford a gym membership, no problem. We can even start from home. Then I give them home exercises. You could do this with body weight. You can get some resistant bands from Amazon. You can get some dumbbells. What do they call it? Free weights. Dumbbells. Yeah, you can get some free weights. You can get started at home as well.
Yeah, they can also use an app on their iPhone.
You can use apps.
Low-cost
The point is to get started. The point is to not shoot for the stars immediately. Let's get moving. But the point is to think of this as a lifestyle.
How do you find the time in such short visits? Because most of insurance model care is 20, 30 minutes at best, and people have a lot of things they want to share or say. How do you fit in the extras about talking about exercise? I used to give people a prescription pad. This is your prescription for exercise. This is your prescription for eating. How do you manage to fit that in realistically in today's world as a primary care doctor?
Yeah, so that is true. And it is a challenge that I have every single day. And it's just about me brainstorming within the capacity that I have. How best can I make it? That's something that I do every single day.
Allowed to bring patients back as often as you want? Is that part of your practice?
Exactly. So that's what I do. That's exactly what I do. And I'm glad you're bringing that up. I tell them that, hey, we discuss these things because I want to make sure that I'm addressing everything that's on your mind, so that whatever you expected from today's visit, we try to make sure that we address those things. But then there's some things I want to address. And we may not be able to talk about those things, but I briefly tell them. And I said, how about we follow up in 2 weeks, 3 weeks, 1 month? And this could totally be a virtual visit. So for this, you don't have to come in with me, come into the office. As long as you're based in New York, I can see you from home. But I do kind of want to talk a little bit more about your diet. I do kind of want to dig a little bit deeper into your sleep. I do kind of want to look into your family history a little bit more. If your exercise is being an issue, let's talk about a little bit of you, depending on whatever is, it's all personalized, right? Depending on whatever point I feel someone needs to focus on, I tell them it's not here, it's not done yet. These are supposed to be annual preventive visits, but I'm not asking you to see me next year. I actually think we should see each other more often.
Patients are happy.
And they're super happy with that. And then they follow up, they go back. And in the meantime, I give them some homework. For example, on the portal, I send them podcasts to listen to. I send them different videos. I send them some books to read.
Send them this podcast.
I'll send them this podcast, for example. Exactly. So anything that, if it's religious. So I have also designed like specific things for sleep, what I want my patients to know. So I've shortlisted some podcasts, some books, some things. For exercise, I've done similarly. For high cholesterol, I've done similarly. for heart disease. Like I've built those things and I keep improving them as time goes. So what I do here so this is me hacking the limited system I have. Let's get you these resources. So you go home, you read up on this, and then let's do a virtual visit and we can talk about what you learned. And then I want to talk to you a bit more. So this means several visits in a year. But I think that works. Like,
you don't have to worry. I know you see 16 to 20 patients a day. So that you must be tired at the end of the day.
Very tired at the end. Ask my husband.
So we already crossed the bridge of you weren't taught much about preventative medicine in med school. How are you educating yourself now to be able to provide the best proactive insights to your
through people like you? And this time, I think since my training, what I've also delved really deep in, I've really understood. Now I follow nutritionists. I read the work of exercise physiologists. I read the work of sleep psychologists, because these were aspects that were not taught to me in my training, right? So, but I guess what my training did teach me was how to read papers and how to be able to discern, what works and what doesn't work. And so a lot of my focus now is to really dive deep into, alongside the conventional stuff, like that's happening, right? We all know the guidelines and we keep ourselves up to date on those things. But some of the things that I really dig deep now into are nutrition, exercise, sleep, even psychology. I try to understand a lot about the mind. I follow a lot of different psychologists. I read their work. I read the books, because I don't think psychology is disconnected from any of this. If anything, maybe the starting point may be that. So, and that's what I try to bring in my practice, that in simple words, I tell my patients, right, if you need this particular blood pressure medication today, I'm going to give you this, because I know that this is what's supposed to be for you right now. But in future, we are also going to talk about I don't just say, hey, go diet and go eat healthy and exercise. Like we know that doesn't work. But then for me to be able to guide them, I need to know what should they eat and how should they move. And if they're having difficulty moving, how should I help them do that? I see that as part of my work with them as well. It's not just prescribing medications. So I keep myself up to date on those things in terms of what are the latest guidelines, what works, what doesn't work, what are the myths. Then I debunk a lot of those things as well, for me to be able to, and I learn from patients too, because they're coming to me hearing a lot on social media, but then I need to know, okay, what's right, what's wrong, what works, what doesn't work. So those are by following the right people and figuring out the material. It's something that I've been able to upskill.
It's all really wonderful. I mean, I'm fascinated, and I think it's a work in progress. It sounds
it is,
to you,
of
but
course,
it is
of course, 100%.
There's a lot to do there.
100%.
Yeah, but you're making progress. So if you could wave a magic wand and change anything about conventional medicine, would there be one thing that you would start with?
I think connecting all the health records. I think the silos have to go. I don't know. I'm not sure if there's value in these silos.
I don't see any value.
I don't see
silos.
this.
Like
it makes my work and it makes things for my patients so much harder than it needs to be. Like if only I could, like when they're coming to me, if only I could see whoever they've already been to, the impression everybody, like right now we're literally talking in terms of faxes, right? Like I get faxes from different offices. Like the most advanced GI practice is faxing.
So
like
one little tip for that?
50 pages.
Faxes.
I think if the doctors can start talking to each other, if the records can start talking to each other, like
So
that
that's
would be my one
problem that I've solved by asking for release of records of all the doctors and getting them, whether they're faxes or, because a lot of doctors don't even use email yet or scan. Yeah. And then the other factor for doctors I find is time. Like they're seeing so many patients a day, they don't want to get on, you get them on a phone for a couple minutes, you're lucky. In my case, having done work so early in this field, doctors used to get angry at me for what I was doing until they saw the outcomes, and then they became my patients. So that was always rewarding, but it is hard because the medical system isn't set up.
It's not set up. It's not set up for success in there.
Let's shift a little bit. I don't know if you have experience, but I would love to hear if you've had experience with GLP-1s. Have you seen patients coming in asking, given it's become a celebrity thing? And how do you approach those conversations? And what has been your experience just out being in primary care?
Yeah, and actually, this is one of the most common things I manage in my clinic, because it's obesity gain has been. I see 70 to 80% women. It's not exclusive to women, but it's a lot of women come to me with issues such as both weight gain, obesity associated complications, And many of them are coming with the intention to explore GLP-1s. And in my practice, I found them to be revolutionary. I'm very pro. I'm very pro semaglutide, very pro tirzepatide.
What is the usual decade age-wise that you're seeing patients asking because they have obesity or what?
I think I would say my majority is 30s to 50s or maybe 30s to 60s.
It starts changing in their 30s and right.
Exactly. That is the time.
Well, I'm as convinced as you and very optimistic because I think these are breakthrough medications like antibiotics that will change the trajectory.
And it's making things so much easier for so many people, even when and if anything, I feel like when they start taking it, all the things that they always kind of knew they were supposed to do in terms of managing their diet, it sort of becomes so much easier for them. I noticed that as soon as the medication starts, now they start going to the gym. Now they start focusing on their protein. Now they start eating the right way.
Once you start it, I think people realize food noise disappears. And it's the food noise that keeps them thinking they're eating breakfast. What are they going to have for lunch? And then they're eating lunch and when am I going to have a snack? And I think we're driven by that because of the way modern society works. We have access everywhere, but I think you're right. And I agree that these are breakthrough drugs. Yeah. So I think I'm as optimistic as you are. And I've seen it over 20 years. So I'm excited about it. Okay. We're kind of running out of time a little bit, but I thought I'd turn the tables and give you an opportunity to ask me anything about the way I practice and how I approach things since you're beginning your new venture into primary care.
I actually really appreciate this question because I had that in mind myself. My question would be, tell me how you do things differently. For example, in terms of as a comparison of what I'm doing. And now if you add the additional layer of epigenetics and genomics, or if there's something else that you're also incorporating in proactive medicine, what difference would that make?
That's a great question and it's massive, but let me tell you that in growing what I did, I realized I needed more time with patients and I needed to make it efficient. So starting back 20, 25 years, I started doing telemedicine and everyone in my family is a doctor, as most of them, they're scattering other things. My twin sister, my brother, my son, my niece. So we're a family of doctors and my family would laugh at me. They think I was getting out of washing the dishes in Thanksgiving because I was in the garage talking on the phone. Yes, I would be getting out of washing the dishes, but I also had to talk to my patient, right? So I designed a way to engage with patients from a distance and creating spreadsheets and information that would allow me to share real data, not just conversations, but actually go through what the patient has eyes on it. I had eyes on it. It wasn't through Zoom because Zoom came later, but through the phone. And equally, I was able to teach other people who would be shadowing me or working with me how to think differently. And then collecting as much as I could. So going back 20 years when computers were like 3 gigabytes, I would constantly crash my computer because people would be sending back their data and the computer was too overloaded. And so I created questionnaires and ways to dig into areas that I knew were pertinent before I even saw a patient, collecting their information and then digging into all of this because there's no way to do it in a 20 to 30 or 40 minutes. And so I was very fortunate to carve that time for myself and to know that I was doing it in a way that was be valuable for both me and the end result for my patient. So that's where I started a long time ago. And now it's developed into having a way. Of course, the care we give here is bespoke and, it's very in-depth along the same lines that you're speaking, but advanced to include all things genomic, all things epigenetic. We even talk to trainers. We have exercise physiologists. I have, other clinicians who work with me. So I'm able to train them and extend and leverage the time because I train them in rounds. In fact, I run it like it's academics, like it's Yale. So we are privileged not to have to see 20 people a day and give them a little bit of everything and then more time. So it's time that is really, I think, a big rate limiting step in primary care. Because I did primary care for a few years as I was transitioning, helping a doctor in New York. And I knew what it took. I think I mentioned before that I would stay till midnight to make sure I could work through all the issues for any one person. There's a doctor I work with who is lovely. His approach to high cholesterol, high blood pressure, or weight was to starve. And I'm like, that doesn't work, only for some people. So he learned as well, along with the patients. And it was very rewarding. I think you also need to be in a system that isn't insurance-based to begin with. It's wonderful if you can help a little bit, But I think the frustration that you might have in the future will outweigh your ability to continue on this level because there's a lot to learn. Yeah.
And this is I agree. Like I said, I am aware that time is the challenge, but we try to make the most of what we have. That's what we're all trying to do here within the limited constraints. How can I still provide? But you're right. Time is where, because these things like 1 hour, 2 hours.
It might help you. One practical step would be to share like a questionnaire of things you think are important before you even meet a new patient. Or if that's hard, once you meet them, send them home with that homework that involves answering all these questions so you can get the detail and the information you need. And that will take you a long way because it's the questions that you need. I'll give you a real example. We have a patient, a longstanding patient who called last week with back pain, severe back pain. And she was a little upset because she was babysitting her 7-month-old granddaughter and she had to bring someone in to help because she couldn't carry the baby. And so in exploring what she was doing, it turned out that she was doing a new exercise. Her farmer's carry was holding weights that was half her body weight because that's what her trainer told her to do, which was insanity. And so that put her back out. And by simply probing and asking the right questions through a phone call, you can figure out what you need to do to help. And so that's how I've learned over the years to make a difference. And
that's
to really
where the extra 10 minutes help, right?
Exactly.
Because you can go deeper than exactly just what they've come with. Sure, I can put a Band-Aid here and fix this problem, but I want to ask you how this happened and dig like 2-3 layers deeper. So then I can make sure that we talk about that too. And then hopefully in future, this doesn't happen.
It's like, I think of it as being a detective and learning all the bits and bytes about that particular human being, because all of us are unique. Even my identical twin and I are not the same. And so by learning that, you can really help course correct the future health trajectory of any person. And that's what we've been lucky enough to do here. So I'm thrilled about it. I always like to ask any of my physicians and other participants on the podcast, if there's one burning question, you meet a person on a plane or a party, and they ask you, what's the most important thing I could do to improve my health? What would you say?
Gosh, in terms of choosing one, I think, like I said, I think it's understanding our own psychology. I think, and sleep is not disconnected from that. So I would say mind and sleep, because everything else, including like working on self-esteem, because those are some of the things I notice in patients, right? Like, why would I think I deserve to do all this for my future health if your self-esteem has to be high for that, right? You want to feel like there's something special to preserve. Like, I see that a lot of people are really struggling with their mind a lot. Like, I see a lot of mental health concerns in even young women, for example, and they want to do things, but in terms of like stress resilience or emotional resilience or mental resilience. And I like to say that with a caveat, because sometimes that may feel like I'm implying that the problem is just in them. That's not what we're saying at all. Our systems are broken. There's a lot of corruption. There's a lot of awful things going on. But I think what we can still have some control over is just having a little bit better understanding of our own mind, our own self-esteem, our own ways of coping up with things. Gratitude comes there, social networks come there, interacting with the right kind of people who uplift your energy, who motivate you, don't push you down. And I think that's tied in with sleep as well, because if you're not sleeping properly, none of this is going to happen. So exercise, diet, everything else is extremely important. But I think mind and sleep, I think that trumps. So as much as we can, we should try to see if we can optimize our mind.
I think that's beautifully said, and I couldn't agree more. But actually, you're ahead of me with that, because when I first started, I was in internal medicine before I did endocrine, and I felt it was all mind and psychology. And I was raised in a family where you got to be tough. There's no weakness. If you're depressed or you're anxious,
then you're weak.
And so I had to get over that. And I will tell you that the biggest thing we do here, it's all about the mind and psychology for every single person. And they have to feel deserving. And you see a lot of women, and a lot of times women are the caretakers. They put themselves last. Their kids come first, their parents come first, their husbands come first, or partners come first. So I'm going to thank you now, and then do you have a way to tell people how to reach out to you? Or
I'm on
social
Instagram,
media?
so they can follow me.
Excellent. Thank you for joining me, Dr. Maryam Baqir. It's really been a pleasure. I feel echoes in resonating with you, and I'm very excited for you because I think your future is really bright. If listeners want to learn more and tune into you, where would you suggest they go? Are you on social media?
Yes, I'm on Instagram. That's my the primary mode of presence. They can follow me there. My handle is Dr. Maryam Baqir. So it's DR and then my name, MaryamBaqir. And I post pretty frequently there. So I would be happy to have them follow me there.
Fantastic. And I will too, if I'm not already. I think we may be following you already. But thank you for tuning in to all our listeners to Healthy Longevity. I'm Dr. Florence Comite, wishing you a health span to match your lifespan.